Good evening and welcome. I'm Nadia Rosenthal. I'm the scientific director at the Jackson Laboratory here in Bar Harbor, and I'd like to thank the Ellsworth Library for giving us this opportunity to speak with Dr. Edison Liu, the CEO and president of the Jackson Laboratory, about his experiences from SARS to COVID-19, my life with pandemic response. Welcome, Dr. Liu. It's great to have you here.
Thank you, Nadia.
Tell us a little bit about this virus, COVID-19. What is it, and where did it come from?
Well, COVID-19 is a coronavirus, and I have a little slide for you, picture of you of the coronavirus itself. It is a virus that actually has been around in humans for a long time. It causes a common cold. But in 2003, there was a remarkable event of the SARS or virus that came about, and it just swept Asia. And when we sequenced it, we found that it was a coronavirus, to the surprise of everybody because it normally is a benign type of virus. But what had happened was that it mutated in a specific way and jumped from a civet, which is a mammal, to humans, and from humans to humans. And subsequently, there was a camel coronavirus called, and then that caused another outbreak in the Middle East called MERS. And finally, unfortunately, we have COVID-19, which started it in a seafood market in Wuhan, China. Now, the origins of that is that it is likely from a bat, because these coronaviruses are in many species, and they cause diseases in those species, but it's when they jump from one species to the next that it becomes very virulent, because usually individuals, humans, if it can be passed on from human to human, we don't have any antibodies, or have no immunity. So you can see that the pictures of coronavirus, the one on your left is actually a rendition, but one on your right is electron micrograph, and it is characteristic spikes that come out, and that's one of the physical features of the coronavirus.
How do you envision that it spread so fast? What made it spread so fast compared to SARS, which I know you worked on when you were in Singapore? This seems to have a completely different trajectory, and I was wondering if you could just explain how your vision of this is.
Well, first of all, how we knew it was a coronavirus was by the new genomics stuff that we do at the Jackson Labs. I was the executive director of the Genome Institute of Singapore, and we were mobilized immediately once we knew it was likely to be a viral source. And the first thing we tried to do, and the two scientists who are here now at Jackson Laboratory, Yijun Ran and Chaolin Wei, were amongst the first, were the leaders of the team that did the first sequence of the coronavirus, of the SARS virus. Once you sequence it, you know the structure of that virus, and then using a computational means, you can then map it back to potentially where it was from. But also, equally important, you're able to analyze the components of the virus, that we do have an understanding of how it functions in a human host. It turns out that those spikes are really the major recognition, the kind of address of that virus against a human cell. And when those spikes actually touch a human cell, if there is a match, then that human cell will take up the virus through a variety of means, and that's how the infection takes place. Well, we know for a fact that the SARS virus had a fit between the spike and a protein on human cells called ACE2. The name is irrelevant, but it's just that it is a unique one. And when we looked at the sequence, when scientists looked at the sequence, it was, we can actually, we can actually infer structure. By looking at a sequence, you can say it's likely to fold this way. And when they did that, they were surprised to see that it was a very good match to the ACE2 protein, much better than SARS, and certainly better than the bat viruses and what have you. This is very pertinent in the sense that it's really only the human ACE2 that will bind to the COVID-19. The mouse ACE2 will not, and it's likely that the bat ACE2 actually does as well.
So this is obviously a brand new virus, at least for humans, and there have been obviously vaccines in the past for flu, and this is a related virus. So why is there no cure? Why don't we have a vaccine, at least in the making or ready for such a pandemic?
Well, first of all, flu and coronavirus are actually quite different, even though they may have the similar molecular principles. Okay, so just because you were immunized against the influenza, you clearly are not going to have any protection against the coronavirus. The challenge of any vaccine is that in effect, you need to know the structure, and you also most likely need to have the virus at hand. In the old days, you made the virus what they call attenuated. You kind of killed the virus and used that as the vaccine. But now, most of the time, it's actually produced. The antigens are fundamentally produced. Well, in order to get that done is technically not that hard. It's engineering. A lot of groups know how to go about doing it. It's really the scale up and the testing that is really difficult. You're not talking about thousands of units. You're talking about tens of millions of units. And to bring that up to that level is quite significant. But there's another very important part of this too, is that not all viruses work. And in fact, rarely, but once in a while, a vaccine, a vaccine won't work, but once in a while, a vaccine will actually make the infection worse. We know that. And that's why it has to be tested in a clinical trial first in order to avoid that terrible situation.
So it sounds like the best way forward is just not get this virus in the first place. So how do I know? How do I catch it? And how do I know if I've got it? And how do I know if somebody else has it?
Well, that's one of the challenges of the COVID-19 is that the symptoms are very similar to the common flu. In fact, there's a spectrum of symptoms from mild to very severe. And the mild one sometimes looks just like a common cold, of which other coronaviruses can also cause. Let me give you at least from the very big picture to the symptomology in and of itself. Let's take a look at the behavior of the virus. Okay, I told you that COVID-19 is very transmissible. People can get infected. In fact, it's more transmissible than the flu itself. And the flu, as you know, can spread relatively easy. On top of that, it's about 10 times more virulent than influenza, the current strain. Now it's more transmissible and it's more virulent, and you've got a very bad combination altogether. And this is why the world is very concerned about this pandemic, especially since, as I mentioned, nobody has immunity to it. It's totally new. The symptoms are like cold symptoms, runny nose, sore throat, and then characteristically there's a cough and fever. And that's what the pneumonia part of it was what brought the epidemic to the notice of physicians. But as we gain better understanding of the virus, and in the last count, there's already over 800,000 individuals who are infected worldwide. We begin to see, like I say, a large spectrum of the symptoms from very mild to death. Things like change in smell, those issues do come up periodically, but it's not one symptom, it's a constellation of symptoms.
So we've heard a lot about social distancing. By the way, if you can see, we're practicing it tonight. I think we're more than 6 feet apart. And I was just wondering if you could talk a little bit about the importance of social distancing.
To control and to overcome any epidemic or pandemic, there are only really 3 approaches. I'll start with the most technological, and that is an antiviral, in other words, a drug that will stop the proliferation of the virus in you, stop it cold. The second is, of course, vaccine, and that is to prevent you from getting the virus. And then the third, which has been practiced as long as there's civilization, is what we now call social distancing. And in other times, they were called quarantining individuals. So social distancing it can be viewed in about two levels. One, community population, and the other is on a personal level. On a personal level, mainly it's to protect you. And that means that we have a respectful distance. You don't get into enclosed areas because it's a respiratory virus, and we can talk a little bit about that, in more than a certain number of people. And you want to keep as far apart as possible. This is why you have these isolation procedures, especially as you may have heard tonight, Governor Mills has basically declared a health state of emergency in Maine, fundamentally shutting down the traffic of citizens within the state to prevent large numbers of people, aggregating that's there. Now, the second level to that is on a population basis, which is to say, we're not going to let lots of people congregate. And that is clearly to prevent the spread of the virus. The virus is very transmissible. And on top of that, we now know that a number of individuals will be infected but have no symptoms and can still infect somebody else, okay? So the characteristics of this virus are really a very stealthy one, and it's the one that is causing us a major problem right now.
And these symptoms that people have, the respiratory symptoms that people have, that's really the core of the problem with social proximity, is that you might be somehow susceptible to somebody else's cough or some kind of waterborne virus that would...
So that's a very good point, Nadia. This coronavirus is primarily spread by aerosols from your lung. Now, it's in other surfaces as well, but as far as we know right now, the transmission is through aerosols. And you get these aerosols by talking in close quarters, by coughing, and by sneezing. Now, the reason why we talk about the 6 feet is it wasn't just pulled out of the sky. In fact, there have been engineers who've studied how far these aerosols actually project using some very interesting technologies. And it's about 6 feet is to the extent. Now, the other aspect of this is that these droplets actually fall down on surfaces. And especially, this is why you're asked not to cough in your hands, because the hands will actually shake with somebody, or when you hug them and you give them a kiss, that is the easiest way to also transfer as well. Now, once it lands on the surface, it can actually infect others while on the surface. We know for a fact that on surfaces, if you just simply ask, can you harvest traces of the virus, you can harvest it up to about 3 days on a surface if it's not cleaned. Cleaning with 70% alcohol is very efficient in eliminating that virus. Now, the aerosols that you get on coughing in very controlled conditions, in fundamentally a box, it will linger in the air for about 3 hours. Now, if there are winds and what have you, of course it changes, but in the experimental situation, it's about 3 hours lingering in the air and about 3 days on surfaces. That's why we're spending so much effort keeping people away. That's why we're asking people not to aggregate in crowds. That's why we're cleaning surfaces as much as we possibly can.
What do you see as a major advantage of testing for this virus? We've heard a lot about tests and the shortages of tests and the relevance of tests. Can you talk a little bit about the role of testing in this pandemic?
Yeah, before I do that, I want to actually finish off with an example of why social distancing is really important, and I have a slide for you for that. Now, this isn't the first pandemic we've had. We've had many in the past, but the most recent one that had a worldwide impact that killed probably 50 to 70 million human beings, killed 675,000 Americans, was the 1918 flu epidemic called the Spanish flu, okay? And when it came from Europe to the shores of the US, the different cities responded differently. And by the way, this is actually a historical study that was done looking at the incidence of cases in Philadelphia in the solid line and in St. Louis in the dotted line. You can see, and in the horizontal line is really over time, right? You see in Philadelphia was that huge peak, and then it came back down. And how in St. Louis, it was this low plateau they threw out. Well, what was the difference? This happened within a week and a half apart from each other, the initiation of the epidemics in the two cities. Philadelphia decided to celebrate by a big parade. They just didn't want to stop anything. They didn't close the city down at all. St. Louis closed the city down. And this is actually evidence, historical evidence, how social distancing as a policy does work. So the next slide will tell you also, this is actually the number of new cases that we see in the United States, okay? Now, we assess how fast an epidemic is actually raging through a population by looking over time how many new cases actually occur. And you can see this one was going up in a really fast clip, which if you fit it into a mathematical model, it would be exponential growth, right? Now, the red arrow actually was when President Trump on March 13th declared a state of a health emergency. And that's when many states began to do their social distancing policies. And what the green arrow is when you see that a number of those cities and states closing down, and you see that instead of an exponential growth, that growth flattens out. And that is what we would call flattening of the curve. And it's telling us that the social distancing is actually working in the United States, as imperfect as it is.
That's fantastic. It's such a relief to know that something is working. Let's get back to the tests, though. I'd love to hear more about how you feel tests are playing a role in in this flattening of the curve?
Well, I can tell you that when the SARS crisis hit, we knew that the most important thing we could do, other than the medical isolation and so forth, was to get a test. So it was sequenced, a PCR test was done, it was distributed throughout the country. The most important issue here was, just like the COVID-19 epidemic, is that it started in the winter at the same time as the seasonal flu. And remember, I told you that the symptoms are almost identical between the two. So you have people presenting to their doctors with the flu, and yet they have this completely new, much more virulent virus that is lurking in their bodies. So a very important part of this is to identify which amongst those people with flu-like symptoms actually had COVID-19, so that we can separate them and not have them infect other people, especially the healthcare workers, because there's a tendency to go to the hospital, the emergency room, and the first people they will infect not only are the people in the waiting room, but also the first responders, the nurses and the doctors. This is, in fact, the reason why we have such a sense of emergency. As the numbers rise and as people get very sick, they're going to go to the hospital. And it's been calculated that at the peak of a pandemic and epidemic, we can actually saturate all hospital beds in this country. That's not good for the patients with COVID-19. It's terrible for patients with a heart attack, with strokes, with broken legs, because there won't be room for them. And on top of that, there'll be decimation of the healthcare workers. So you have a double whammy in the healthcare system, which we desperately want to avoid.
I've wondered if you could talk a little bit about another term that we've heard a lot about called herd immunity, something that has come up a lot in terms of how to sort of epidemiologically deal with these pandemics. And since you've seen several of them, I'm wondering what's your opinion of herd immunity? And first of all, what is herd immunity?
Herd immunity is a term that is frequently, misunderstood. Okay, and it's the idea, in the absence of vaccine, okay, it's the idea that you let an infection go through an entire herd, okay, so that the herd is now immune from a second wave of the virus, right? Because once you get the virus, and COVID-19 is no different, individuals who survive the virus, and many do, okay, because the mortality is, I mentioned to you, between 1% and 4%, you're not likely to get it again because you have immunity against it. Now, in order for us to prevent a second wave, what happens is that with a herd immunity, you may be susceptible, but all the cows around you, okay, all the people around you are already immune, and therefore you won't be able to spread it. Even though you may get it, or a small portion of the population may get it because they're susceptible, the rest will not, and will not spread because they're immune. In order to achieve herd immunity, about 70 to 80% of a population need to be rendered resistant. Okay, it depends. But here's the problem: if you let 70 to 80% of the American population to actually have COVID-19, that means, let's just say it's 300, just round it off, 300 million Americans, let's say, are allowed to have COVID-19. At even 1%, that means 3 million Americans will die. That means that 30 million Americans will have to go to the hospital. That, to me, is not the price I want to pay for the natural herd immunity. What is very important is that vaccines give herd immunity. Vaccines, in effect, is like giving you an infection without you having all the side effects of that infection. That's how we as a humanity, as mankind, eliminated smallpox, was mass vaccination on a worldwide basis. It gave herd immunity in such a way that even if it cropped up on an intermittent basis, it would not spread.
And given that we have this prospect of being able to overcome the virus by a sort of an engineered herd immunity through a vaccine, what do you think is the most promising direction that research is going right now, either toward a vaccine or other treatments that might be effective in slowing this surge?
Well, I'm going to start with antivirals, vaccines, and then let's call it new technologies for social isolation, okay? Because I think it is worthwhile to talk about that. Antivirals are drugs that stop the growth of the virus in you, okay? They're very effective, when the right one is chosen. And they're also effective in slowing down the, eliminating potentially the much of the mortality, but also can slow down the progression of an epidemic. Several antivirals are already being produced, some of which have been shown anecdotally, and the clinical trials are advancing very quickly to have effect. It's been shown that in culture, in cell culture, some of these drugs actually do slow down, if not stop, the replication of the virus. Now moving it into both animal models and in human clinical trials, there's great hope that it's going to emerge. And in fact, several have been more or less approved by the FDA to move forward in these trials. I would say that this is more likely to come on board before a vaccine. Mm-hmm. For the reasons I mentioned to you, you need tens of millions of units, and you worry about actually vaccines that can make things worse. Now, the social isolation, I think, is, there are also new technologies in terms of the social isolation. For example, the idea that what China did or what Korea did, and it's already being contemplated in New York at this point, is moving individuals who are not seriously ill, have minor symptoms, but are proven to be COVID-19 positive into intermediate care facilities that are not hospitals. That actually originally was done because you wanted to not flood the hospitals, but there's probably, this has not been proven, but there's probably some benefit in that individuals that are constantly being dosed with new waves of COVID-19 viruses, like you might have in a hospital situation where the person next to you may be very seriously ill, may actually get a more dose of the virus than you would in the outside. So more and more, that kind of, the Chinese built an entire 1,000 bed, they called hospital, but it really was a holding facility for quarantine in 8 days. So that kind of technology has really made a difference.
So here we are in Hancock County, and you're the CEO of the largest employer in this county. What steps has JAX taken to deal with this pandemic and to limit the possibility of infection among our own employees?
Well, first thing is communications, to really be upfront and clear about both the risks and the mitigating or the factors that would reduce the risk. We were very open about this. We have a website, we've had group meetings, we've had many forums to do that. a very important part of what we're doing is we identified individuals whose jobs allow us to deploy them at home. And we really didn't make it an option. We asked those people to go home. Now, a very important part of this is I need to say that the workplace inherently is not a dangerous place. The only dangerous place is when you aggregate too many people together. By thinning out the workplace, and we have essential workers here. Many of our workers are doing things that we will talk about, I hope, that will help solve the COVID-19 problem. We want to make the essential workplace safer for those individuals. So by thinning the workplace out, by actually putting people in shifts, by increasing the cleaning that we have, by enhancing the social distance so that we never have more than now 5 people in a room at any one time, and they have to be at least 6 feet apart. And on top of that, what we have done is in the last 3 weeks, and now coming on 4 weeks, have stood up a COVID-19 diagnostic down in our Farmington, Connecticut laboratory. The primary reason is that there's not enough capacity in any of, across the country. And we wanted to make sure that the capacity was going to be available in the areas that our workforce is at. We still don't have infinite capacity, and what we're hoping to do is actually work very closely with the states of California, Maine, and Connecticut to help, at least in our own way, to reduce the demand and increase the capacity for COVID-19 sequencing.
And are there other things that are going on at JAX that are sort of perhaps more long range, other ways to harness our capacity to do some cutting edge research here at the JAX that could actually be used in the COVID-19 war?
Absolutely, and this is where perhaps better than I the utility and capabilities of these. I'll start out, and I'm going to ask you the question. There is like I told you already, that the COVID-19 virus will not infect mice, which is the major research animal, but it will infect humans. So you really need an animal model to really be able to test conclusively whether an antiviral will work or not. It's absolutely essential. And so in 2007, an investigator in the University of Iowa actually constructed a mouse with a human receptor for the COVID-19 called the ACE2, right? So in the mouse, instead of having only the mouse ACE2, it actually has the human. Well, this mouse is amenable to be infected by the SARS, MERS, and also the COVID-19. Well, 2007 was a long time ago, and so JAX, being who we are, we're able to resurrect the line, and actually is in a massive expansion phase to prepare to give to the rest of the nation and the world a model that we can actually test the effectiveness of antivirals. Now, I'm going to turn to you because you know much more how this reagent, this resource, can actually be used, in a large scale.
Well, certainly the mouse that we have now that we're sending around the world is really needed and is in high demand. It has a few shortcomings, however, and one of them is that when you make lots and lots of something in a mouse, it doesn't always mean that you get more and more of the response you're expecting. So we know that this mouse is making all of the proteins that the virus needs, and is indeed making the right human protein, that ACE2 protein. But the problem is it's making so much of it that it doesn't really mimic what's going on in the human. And so we're in the process of tinkering with the mouse gene and turning every little bit of it that is different from the human into the human, so that eventually we will have what's called a humanized mouse. We can then use that mouse in conjunction with many other mice that we have developed here at the Jackson Laboratory, in which we've humanized the immune system to be a human immune system. And what we're trying to do is getting closer and closer in the mouse to the kind of response that a human would experience if it got infected, if he got or she got infected, so that then we can try out these treatments on the mouse. Now, we, as the Jackson Laboratory, don't do highly infectious research for obvious reasons. We have 2 million little furry mice. We do not want them to get sick. But what we now have is some fantastic new expertise in our Connecticut campus, where scientists are actually taking the most important spike part out of the COVID-19 virus and putting it into a harmless virus. Now, that virus can actually get to the ACE protein on the surface of the mouse cell or the human cell, and that protein can sort of ferry that piece of spike into the cell. And so we can study the whole way in which this infection occurs without the danger of a full infection for humans, because this is a completely disabled viral construct that was made to be completely uninfected. And what that allows us to do is to test a whole slew of different ways in which we can prevent that entry right in the cells in the dish in the lab. So there are many different ways that we're really trying to approach it.
It's a prevention tool. It could be used as a prevention.
It is definitely a prevention tool, and it could be used to find ways to either vaccinate or to render humans much less susceptible to this virus, which obviously is the big goal at this point.
Well, this is why, you know, as bad as this pandemic is, and it's a significant pandemic that is sweeping the world, we're going to get over it, and we're going to get over it primarily by working together to keep the social distancing policies going. But very importantly, the science will carry the day. We will have a vaccine, and we will have antivirals. And we don't like the fact that it's a new pathogen in our midst, but I'm confident we can work through it. Now, having said that, let me give you my final slide. But this actually is an important slide relative to Governor Mills' pronouncement today. Why did she say from April 2nd to April 30th for this emergency and shelter-in-place order? It's because of this projection, which is a mathematical projection from the Institute IHME in near the University of Washington. And it shows actually a projected increase in number of serious cases hitting Maine, not the United States, but specific for Maine. And it's estimated that the peak of this, if social distancing really can be imposed, will occur sometime in the third week of April, and it will decline after that if we can continue this process. So what she's trying to do, and very rationally, is to get ahead of that curve, okay? Is to instead of saying, let's do it at April 20th, let's start doing this in April 2nd and flatten that curve out. And I just I applaud her for having the courage to do this. So
that's great. I was wondering if we could take a few minutes to just hopefully get the audience to provide us with a few more questions. But in the meantime, I have a question for you, Ed. What myths about this pandemic are available for debunking? How can we get rid of some of the misconceptions that are floating around in the media and the social media?
Yeah. The biggest one is that it's a mild disease, that it's a hoax, that it's a super exaggerated. The problem here is that there's a highly differential effect. If you're under 50, you may have primarily mild flu symptoms all the way to some severe ones. People have died under 50, don't get me wrong. But if you're over 70, your chance of dying is potentially 1 in 10. So it's quite significant. And everything in between, between 50 and 70. So when I hear somebody say, oh, this is just, it's just like a cold, that is totally wrong. And it should be completely debunked. The second issue here is, what's the big deal? People get a cold and get over it. Well, if it swamps the hospital system, we're cooked. So we can't have that happen as well. So those are the two really major ones that I believe should be debunked.
So I see a few questions. I'll just I'll give you a couple of them here. One question is, how has our virology and/or genetic knowledge changed since SARS? What new knowledge can be used to develop a vaccine faster or more accurately?
Well, I can directly answer that because I was in the middle of the first one, and of course we're in the middle of the second one. It's really quite remarkable. Our sequencing technology was, in retrospect, so primitive in those days, even though they were unbelievably advanced. It took us weeks to get the type of sequence data that they did in one day. And it was broadcasted within an extraordinarily short period of time. The development of the diagnostic was phenomenally fast. The only problem is we did not step on the accelerator in expanding that capacity. The second issue here is that most systems were prepared. As bad as it was in China, listen, we have now exceeded China in number of cases, okay? And so this is, they actually were able to compress it. Singapore and Taiwan literally continue to have commerce in the streets, but they did so by having very stringent tracking system and isolation systems, for them. So the response is really fantastic. And on top of that, the antivirals were already in place. Many of the antivirals I'm talking about right now had been tested for either SARS, HIV, or Ebola, and they're just pulling them out to really repurpose for COVID.
Thank you. What do you think the scientific difference between SARS and COVID is exactly?
Well, I mentioned to you the behavior of the viruses in the human host. SARS is less transmissible, but much more deadly, affects a whole range of ages. COVID is much more transmissible, less virulent, but 10 times more virulent than influenza. But also the morbidity is actually quite different. Why it affects the elderly in the manner that's hugely different than the younger, nobody really knows right now.
So what's the difference between an epidemic and a pandemic?
That's a very good question, and it's a matter of scale. Both are pathogen-induced. An epidemic usually is constrained to a region, and pandemic is everywhere. So for example, the influenza pandemic of 1918, 1919 affected the entire world, okay? Just as much as a COVID-19 is affecting the entire world.
And could you talk a little more about the guidance when they were dealing with SARS and the general public wearing masks in Singapore when you were working with that?
Yeah, that's when we started to realize how the certain, not all masks are alike. I don't want to go into the exact details, but there are the surgical masks that doctors wear are really to protect the patient from the doctor. Okay, because as I mentioned to you, all you have to do is speak, and you'll actually spray. But it doesn't protect the doctor or the nurse from the patient because it's not a tight seal. For that, you need a special mask, and the ones that are most commonly used are called N95, okay? Now, the question is, do all masks help in a pandemic? You hear varying accounts. Some people saying, if you're not ill, don't wear a mask. Primarily, that is stated because we don't want a run on the masks and not have enough for our healthcare workers. But it is true, if you have any symptoms whatsoever, if you want to protect people around you from your own aerosol spray, a mask is actually helpful.
So another question that comes up is that if this aerosol lasts for 3 hours in the air, should hospital rooms that have patients being examined be somehow closed off for 3 hours to protect the next group of patients? Or how do we handle it?
That's a very interesting question. And in fact, this is one of the reasons why the advice of all your doctors is if you have flu-like symptoms, don't come into the office, okay? And this is a technology issue. Telemedicine is going to be a very different and very important adjunct to the control. The second thing is that there are indeed decontamination approaches in hospitals at this point. The challenge, and that's the other reason why we're very concerned about overloading these hospitals, is that you can't decontaminate and have a constant flow of patients as well.
There's another question about the spread of the virus in droplets or just simply in the air itself.
No, it's always in droplets. And these droplets can be very small, as we would call the aerosols.
So, and what are your thoughts on wearing a clean face mask? Is it safe? Isn't it safe?
A cloth mask.
I'm sorry, the cloth mask.
Yeah. As I mentioned before, the mask other than the N95 protects others from you and not the other way around, okay?
Right.
Not that well.
Right.
But one thing about the cloth mask, it's very common in Asia. Everybody wears it. My personal feeling, then not everybody will agree, is that it doesn't hurt and it can help, okay? But one of the key issues is you've got to wash that. You got to wash those cloth masks if they're not disposable.
Right. So could you talk a little bit about the status of chloroquine as a medicine? We've heard a lot about that from the president.
Chloroquine has been shown in vitro, that is in cell cultures, to fundamentally block the processing of the virus as it enters the cell. And so the theoretical component of it is that it may reduce the spread of the virus, once it kind of begins in a little bit way like Tamiflu does in the flu. There are clinical trials that have showed some effect of this. I haven't followed the extent of those studies, but I've just heard, I believe the FDA had approved it for some indications, and I think that people who are more directly involved in patient care should answer that question.
Okay. So what modifications were made to the SARS neutralizing antibodies to evolve them into neutralizing corona? Do you think that this is a promising therapeutic, or are you concerned that the possibility of an antibody response increasing mortality, which happened in dengue, actually?
Yeah, I mean, the person asking the question, Lily, I believe, is quite astute about this. And
Sounds like a
dengue
scientist.
is a situation where we don't want in the COVID-19 vaccine. If one is vaccinated to one strain of dengue and get the other, there's, I believe, 4 or 5 strains of dengue, you can actually get hemorrhagic fever, which is the worst manifestation of dengue. That's a little complicated here, but I'm not sure the issue of getting SARS neutralizing antibody to evolve them, but we know that it's already being tested of taking individuals who've been through COVID-19, generate neutralizing antibodies as a natural response, and having them volunteer their sera to extract the antibodies, and the antibodies being used as therapy for people with severe COVID-19. There are several groups now working on that.
There's another question about, a specific question about antigen development, in this case, egg-based vaccine antigen development for COVID-19. A question about whether that's a workable way forward for vaccine development.
Well, I'm sure that the vaccine creators are trying to do whatever they can. Now, the challenge is it's not, I don't know if the COVID will actually replicate in eggs. So that's actually a key point that I don't understand. The Moderna vaccine is actually an RNA vaccine. It's not even a protein. We can get into the details of that, but there are many groups working on that vaccine right now.
So this is a question for the Jackson Laboratory. How has COVID-19 affected JAC's presence and or activities in China, specifically the partnerships with Wenzhou Medical University? Wenzhou, sorry.
Well, the partnership with Wenzhou is actually quite narrow, and it's around a specific eye pathology and interaction. So we're really not working that intensely with Wenzhou. I just received a letter, a very nice letter from the president of Wenzhou University wishing us well. So there's a lot of goodwill. In the context of Xi'an, where we have Charles Li has a very interesting genetics laboratory there. They are, fundamentally in lockdown right now. Not so much, the lockdown per se, but there's been no traffic between the two institutions, and several of our individuals there have actually volunteered to go into Wuhan to help because they're physicians to help with the crisis. I can tell you that they're doing fine, and the crisis is more or less over in Wuhan at this point.
So this is a sort of a question about evolution. How does a virus like this originate? I actually wonder, why is it that this virus is so good at infecting people, and yet it hasn't infected anyone until now?
Yeah. Well, first of all, there's this fantastic article by Ian Lipkin, and that really goes through all this, what we know now of both the sequence and the structure and so forth. It is a beta coronavirus that clearly is related to the bat coronavirus, okay? By looking at the sequence, he and his colleagues basically asserts that the spike protein evolved uniquely to fit the human ACE2 protein well, and that is the transmissibility, okay? There is this rumor going around that this was somehow engineered as some kind of, in a laboratory and it got loose. He actually addressed that very rationally and said, if I were a germ warfare type of person, or even a genetic engineer, I would have never guessed that this would be the sequence. Normally what you do is you take a virulent strain, clip it out, and put it into this, okay? There was nothing like that. So the argument, therefore, it was just a fluke of by the way, the bat coronavirus mutates all the time in bats. So the sequence we have of the bat coronavirus is from one bat, not the many variants that are there. Bats and humans don't get together very often, but for whatever reason, in that place, in Wuhan, they kind of did. And it's 1 in a million, 1 in a billion chance, and it passed over. The most unusual aspect of it is how, unlike the SARS, where it required a series of passages to human hosts before it really evolved into something that could really be transmitted, this just jumped right in and raced through.
Well, there's another question about whether UV light can kill this virus, with the idea, obviously, that on a soft or a hard surface, you could shine UV light on this and kill it as long as you didn't shine it on people.
Well, of course, but to be honest with you, 70% alcohol does
better.
And faster. And so I would do that.
So what are your thoughts about testing for antibodies and allowing individuals to be less restricted?
It's a beautiful question, and that's what a lot of people are trying to do right now. Not only is that an important point, but it also gives us an opportunity to calculate the modelers, to calculate the issue of herd immunity.
Right. That's right. Finally, Ed, where can people find out more about this pandemic and about the details as they arise?
Maybe my last slide, I put in just three sites, and 2 of them are at JAX. There are many sites, let me just assure you, that are out there. The CDC site, the Center for Disease Control, and the WHO are probably the go-to sites that are there. Our 2 sites here, including one that is called the CEO's Corner, kind of collates a few of my talks, some writings that Jill Goldwaite and I have done for the MDI Islander, which we've recirculated here, and the site, the IHME site, for the cognoscenti, for the people who are really interested in delving into mathematical predictions. That was, and it's a running prediction that is given all the data that's coming out. They will actually give a prediction for how many cases would require hospitalization on a state-by-state basis. I think in the context of for Maine, I've been through a bunch of storms, and so have you, okay? And I've been so impressed with the resilience of Mainers. They say, well, it's category, 18, and this, I'm just joking, but a high category storm, we'll wait it out, and we just have to be safe while it's happening. Let's view this in many ways like a storm in Maine. We know it's going to be over, okay? But let's stay safe during this period of time.
Well, Dr. Liu, thank you very much for your time. And again, thanks to the Ellsworth Library for making this presentation possible. All of you, stay safe, stay well, and good night.